Hey everyone, it's Dr. Hodges, and today I wanted to do a little deep dive into a study that I have referenced several times, and I wanted to go a little bit more in depth. Medscape is a website that kind of compiles a lot of different studies. It offers CMEs to physicians, and so it can gives you I get like daily and weekly emails on various topics in surgery. And then at least once a month, I get a deep dive specifically in the field of obesity and obesity medicine. And so this past June, they had a whole list of thanks. They had a whole list of studies, and they wanted to highlight the one that was published and reviewed at ASMBS, and it was specifically looking at the comparison between surgery and GLP-1s. Those are the injectables like Wegovy, which is Ozempic, versus Zepbound, and which is also Mounjaro. And so basically, they wanted to compare which has better efficacy. Where are you losing more weight? Because when you look at, and I'll put these up, some pictures of this, when you go to the websites of the makers of Mounjaro and Wegovy, you will see that they say patients will lose about 25% of their excess weight. What that means is for every 100 pounds that you're overweight, probably going to lose about 20 pounds. And that's generally what I see in my practice. And, that when you're looking at a study, that is in a controlled environment. And if you drill down to the different studies, that not only do they have the patients on the medication, but if you really look at those studies, the patients are also on a highly structured diet, and they have them doing exercise for X number of a week. So when you are looking at those outcomes and those published, and that's what you're seeing on the commercials, you're looking at a test group in an ideal situation. What's nice about this study that just came out this past June is that they said we're going to have surgery, and then we're going to look at what the published data is for medical weight loss. And then what it really is, what we're seeing in our practice, when patients are not always exercising and when they're not sticking with their diet, but all they're doing is just taking the medicine, hoping that the magic happens. What are their outcomes really? And it was very interesting to see what the outcome data was. And so the take-home message is that people who undergo bariatric surgery, they will lose 5 times the weight that a patient will lose over a 3-year period if they're doing in injections. And that is looking at comparing surgeries, bypass and sleeve, to both semaglutide and tirzepatide, which is Wegovy and Zepbound. So the use of GLP-1s, they've definitely surged over the years, but they haven't really had a direct comparison. And this was the first time that a large study was done. Researchers used a retrospective study, meaning they looked at old data for patients, and they looked at over 50,000 patients. So it wasn't just a small study of like 50 people. They looked at 50,000 patients. And they looked at patients, and they had a BMI over 35. How well did these patients do? And they looked at the group of patients was between 2018 and 2024. And they looked at the total weight loss over a 3-year wait period. And this is what they found, is that clinical trials will show weight loss for GLP-1 between 15 and 21%. So that's 15 to 20 pounds for every 100 pounds. But in the real world, it is considerably lower. So half of that. And then of people that start medication, within a year, 70% of patients will stop that medication. So only about 30% of patients that start medication will remain on it for at a 1 year's time. And when you looked at patients who used GLP-1s continuously for 1 year, they lost 6% of their total weight, but that was still clearly that weight loss was still significantly greater in those who underwent bariatric surgery. And there was a 5-time difference in the weight loss between patients that had had surgery versus patients that had had medicine. So for instance, like if I have a patient that comes in and they're having a sleeve, I can pretty much hang my hat. If you have about 100 pounds to lose, you're going to lose about 60 to 65 pounds. If you are a patient that has 100 pounds to lose and you have a gastric bypass, not a sleeve, bypass, you're going to lose about 75 pounds. Whereas if I have a patient that's coming in and they want to start medication, whether they have 30 pounds to lose or 130 pounds, they're probably going to lose 20, 30 pounds. So that's a significant difference. And what also we are seeing with medication is not only are patients falling off from the treatment, so consistency is key. The other thing is that patients are they're just not reaching their weight loss goals. So that is when it kind of comes down to who is a good candidate. There's like what the research says, and then there's like what I see in my practice every day. If I have a patient that comes to me and they're wanting to lose weight or they want to help to maintain their weight and they have a BMI of 29 or less, they're probably going to be much better served with medication. However, I thoroughly endorse and agree the new ASMBS guidelines where if you have a BMI over 30, surgery is going to be your best option, because what you need is something that's going to get the weight off and also offer better longevity of your weight loss. Now, what we don't have a lot of studies on is what are the outcomes if you mix the two. And I agree with, there was another study that just came out, or there was an article that was published in General Surgery News. There's a really big practice out of New York, and they have integrated medicine similar to how I have, and it's like a continuity of care. I think medicine is really good sometimes for patients that have a very high weight and maybe to help them lose a little bit of weight before they go to surgery. Or if patients maybe have a BMI of 28 or 29 and they want to lose 20, 30 pounds, that is when it's ideal. Surgery is going to be best for BMI over 30, but then you may find that patients do well, have their surgery, and then have their adjuvant therapy after they've lost weight, like maybe at around 6 to 9 months, maybe add in a GLP-1, and that's going to really help knock off that last 20 pounds and then really help them with that longevity of weight loss. Because you have to remember, when you have a BMI over 30, you have the disease of obesity and all of the little pathways that govern appetite, that govern how your body best utilizes glucose and fatty acids. All of those pathways are going to be skewed and diseased. And that is when medicine along with surgery can really help best treat that. So I think we really need to change our approach to the treatment of the disease of obesity. And clearly, this study that came out and that was presented this past June outlines the superiority of surgery over medicine. I thought it was interesting. That same month, there was an article that said, is surgery obsolete? And the reality is that only 1% of patients that are a candidate for surgery will ask and undergo surgery. So we are woefully undertreating the disease of obesity in the US. Is diet and nutrition important? Absolutely, hands down, emphatically, yes. But once you get to a certain point, you just need to make sure that you're offering your patients the best treatment. And if your BMI is over 30, the best treatment for you is going to be surgery. So hope that this helped, and stay tuned for our next Medscape deep dive.